Given the present limitation in the clinical management of patients with hepatocellular carcinoma, circulating tumor DNAs and non-coding RNAs are emerging as potential biomarkers for hepatocellular carcinoma diagnosis, prognosis, and evaluation of the response to therapy.
We can analyze this nucleic acid exploiting the liquid biopsy, which is the sampling and analysis of biological samples such as blood and urine. One of the most important advantages of liquid biopsy is its non-invasiveness, so we can perform repeated sampling and we can monitor the disease along the time. Up to now, liquid biopsy has several clinical applications, from the diagnosis to the prognosis, to the drug response and resistance to therapy evaluation, and to the tracking of the minimal residual disease. Circulating tumor DNAs has been used to reveal tumor-associated biomarkers. In particular, circulating tumor DNAs gives a straightforward information about the presence of the tumor. However, this analysis is not able to detect circulating tumor DNA at the earliest tumor phase. And albeit this limitation, very promising and exciting results are emerging. In particular, increased serum level of GSTP1 gene in HCC patients correlated with the tumor grade and size, short overall survival, and metastasis occurrence. Furthermore, a panel of 4 aberrantly methylated genes were able to detect hepatocellular carcinoma patients when compared with healthy individuals and with patients with other benign liver disease. In the cancer gene mutation field, patients which showed plasma RASmutation were observed to better response to rafametinib plus sorafenib instead of the only sorafenib. So, circulating tumor DNAs were able to improve clinical management of hepatocellular carcinoma patients from the diagnosis to the choice of the better treatment. Exploiting liquid biopsy, we can also analyze circulating non-coding RNAs. In particular, circulating RNAs are present in all individuals, and differences between cancer patients and unaffected individuals are only quantitative. Albeit a lot of results emerged in this field in the last years, these are extremely heterogeneous. This is due especially to the different sources, serum or plasma, which were analyzed, differences in pre-analytical and analytical procedures, and these studies also showed very different experimental designs. Albeit these results were extremely heterogeneous, some of them were very promising. In particular, several studies show that even if one microRNA is not able to diagnose hepatocellular carcinoma patients, if we combine microRNA in panels and we associate these miRNA panels to alpha fetoprotein levels, we can be able to detect hepatocellular carcinoma patients and distinguish them from cirrhotic and hepatitis patients. Moreover, a lot of studies focus their attention on the miR21, which is one of the most studied microRNA in hepatocellular carcinoma. These studies show that increased circulating miR21 levels were associated to cirrhosis, tumor stage, presence of metastases, disease progression, low overall survival, and low progression-free survival. So, they all demonstrated that increased circulating level of miR21 was a biomarker of poor prognosis in hepatocellular carcinoma patients. microRNA were also used to predict sorafenib response. Indeed, up to now, we don't have biomarkers for this purpose. Patients which were treated with sorafenib and showed an increased level of miR221 and 191A5P had a better response to the therapy. So, increased serum levels of these two microRNAs correlated with a better response to therapy. Albeit these results are very exciting and promising, this remains inconsistent. To change the present condition, we have to implement technology sensitivity in order to detect circulating tumor DNA and non-coding RNA variation also in the earliest phase of hepatocellular carcinoma. Moreover, we need prospective, well-designed, large multicenter trials with appropriate control population to be compared with hepatocellular carcinoma patients. Indeed, we need to distinguish hepatocellular carcinoma patients not only from healthy individuals, but also from patients with other non-malignant liver disease. Finally, we will need a method and data analysis standardizations. Indeed, only in this way we will obtain reliable and reproducible data. Only solving these problems, liquid biopsy and the analysis of circulating tumor DNA and non-coding RNAs will be able to enter in the clinical management of hepatocellular carcinoma patients.